Coming up today, a bride-to-be put her wedding plans on hold due to chest pain and dizziness. Coming up, see the procedure that fixed her heart and had her back to her routine in just a matter of days. Good morning, I'm Jessica Lovell. Welcome to the Morning Medical Update. Kaylee Patterson was born with a heart defect. Surgery fixed the problem when she was still a baby, but that fix did not last. Alexis Del Cid shows us that when her heart problems returned, she became the very first person in our area to get a certain type of implant.
If you really want to see Kaylee Patterson light up, just ask her about her job.
Oh my gosh, I love it.
Working as a special education teacher with the kiddos at Kip Endeavor Academy is what fills her heart. But her heart has had its share of complications.
I was 19 days old when I had my first heart procedure. I was born and my valve was not letting blood go out into the body. So the doctors had to go in and open it up.
Kaylee would have another surgery when she was 14, and for many years after that, felt great. So much so that when she started having chest pains, chest pressure, and dizziness when she was 29, she dismissed it.
First I was like, oh, I'm just getting old.
Out of the mouths of babes. Let's be clear, she was only 29. Kaylee would have her third heart surgery, a valve replacement. They did it all through your leg.
Yep, all through my leg. Like no opening up my chest, nothing like that. And I was able to go back to work in a week, which was kind of surprising. Dr. Zorda was like, yep, get on the treadmill for 30 minutes a day, go back to work in a week. It was amazing.
She affectionately calls her cardiothoracic surgeon, Dr. Trip Zorn, and cardiologist, Dr. Peter Tadros, the dynamic duo.
I love those two. Dr. Zorn is so to the point, he's very professional, and he's just so kind. Dr. Tadros, I don't think I've ever met a person who just brings so much calm to a space. I just wish I could hang out with him.
And Kaylee now has an important message for anyone watching. Never dismiss symptoms having to do with your heart, no matter what your age.
If you're having chest pain, it's better to get it checked out than to just let it simmer.
And we're so glad to have Kaylee joining us this morning. How are you?
I'm doing very well. How are you?
I am good. So good to see you doing well. Also here in studio with us is Dr. Trip Zorn, a thoracic surgeon here at the University of Kansas Health System. He is also surgical director of cardiac surgery and the surgical director of the structural heart program. Had to take a deep breath to get all that in.
Well, thank you.
How are you doing?
I'm great.
I know you have a busy morning. You're scheduled for a surgery coming up here in a bit, so let's get to it.
Sure.
Let's do it. So Kaylee, you were born with a heart defect, as we had mentioned in that story that Alexis told us. They're uncommon, but not extremely rare. You had surgery as a baby, then surgery at the age of 14. Were you expecting to then need another surgery after that?
Yeah, I knew that at some point I would need to replace my pulmonary valve. My pediatric cardiologist, Dr. Gertz, told us the timing would be determined based on the growth of my right ventricle. He told my family he wanted to wait to see if we could hold out for a non-invasive procedure, but ultimately that I would need to get the valve replaced.
What's that like, knowing that you're going to have another procedure?
At this point, I'm somewhat used to it. I think going through it my entire life has made it to where that is just my reality. Whereas I think it would be harder if this was something that suddenly appeared and we were not planning for it my entire life. So this is my norm. I don't know any other way.
Your norm, that's a good way of putting it. You ended up needing that heart valve replacement. You came here to the University of Kansas Health System. Did you have any clue that it could be done without open heart surgery, though?
Well, as I said, Dr. Gertz really tried to hold off for a non-invasive procedure. And I had been keeping updated on heart procedures as I was growing up because I just really wanted to avoid open heart surgery as much as possible. And the procedure I had in high school was also non-invasive, so I had an idea that it could be done. So when it was finally confirmed, I was very happy. I had to do some tests and an angiogram to confirm that I was a good candidate. But once everything was said and done, I was just thrilled.
I bet. What did they tell you was going to happen? What did they tell you from a patient perspective to expect from this particular procedure?
They told me that I would be put under, and they would take a catheter through my leg up into my heart and replace the valve that way. And that they did say that it would take a while, or take a little bit, for me to recover and get back to feeling like myself again. But it was very interesting because my high school procedure and the one that I had in August it took a while to get back to being normal, or what I would consider normal.
Well, I want to bring in Dr. Zorda to talk about just that, because you do a lot of work in the cath lab. But what are the main differences for a patient between open heart surgery and a catheter procedure? We hear the word surgery, we hear the word procedure.
Yeah.
Open heart sounds like this big deal, lots to recover from. What are the differences?
So obviously the first one is the level of incision. So when we do open heart surgery, we have to divide the breastbone for the most part, for most operations, and the length in the hospital and the length of recovery is longer. So the line between a procedure and an operation has blurred, and so much of what we're able to do now based on catheter technology is usually procedure one day and home the next day, and the return to function, as far as being able to take care of things at home and go back to work and those kind of things, is much quicker. So it's within the first week after a catheter base, and usually it's 4 to 6 weeks after open surgery.
And exciting to know that you get to tell those patients, get up, get out of here.
Yeah, no, it's good. They're walking in the, you go do the operation and you go back and see them that afternoon, and they're already making laps in the halls, and they look and they feel better.
That's good stuff to see.
Yeah.
So let's talk about Kaylee's original heart defect, the pulmonary stenosis. What is that? And we have an illustration. You can kind of show us what we're seeing here.
Yep. So on the left side of the panel, you can see the blue outflow tract there is the pulmonary outflow tract, and it's got a valve structure there that's normal. On the right side is what Kaylee had, which is the valve doesn't develop normally, so it barely opens. And the chamber just below that is the right ventricle, and its job is to pump blood through that valve out to the lungs to go get oxygen. But that valve is not opening, so that ventricle has to work really hard to be able to pump blood to the lungs.
So the problem was fixed as a baby. Why didn't that fix stick?
So that's one of the hard parts about operating on babies when they're, they weigh no more than 10 or 15 pounds at the time that they have surgery, and you've got the correlative size of the valve there. And so you're trying to take a 5 to 10 millimeter valve and make it last to adulthood when that valve grows to be 25 to 30 millimeters in diameter. So there's no real way to repair that valve that will endure and last. And so what we do is we get rid of the obstruction, and it leaves them with pulmonic regurgitation or insufficiency there. And they typically do well with that until they get to adulthood. And then we need to fix that so it's not a long-term drag on the right ventricle.
All right, so you two, and Kaylee, thank you for letting us take a camera along inside the room where your procedure was happening. We want to take a look at some of this video, and then Dr. Zorda, kind of show and tell what we're seeing here.
Sure. So this is a device from previously. That was our ASD closure. So the novel thing about this valve replacement is this stent frame that provides a landing spot for us. So it's basically a landing pad. And you can see it's partially deployed here. This catheter right here is delivering contrast, so we can see the anatomy of the blood vessel here. So that's Dr. Tadros there. I'm the tall, goofy-looking guy right there. That's one of our colleagues who is there from the company that makes the valve to help us with that. That's one of our most experienced cath lab personnel that's done a lot of these valves with us, Kathy Coe. This is the tube that delivers the valve up through the femoral vein. We kind of dilate that area and deliver it. So you can faintly see the previous stent that we put in here, and this is the new valve that we can condense down to a small profile to deliver through the vessel, and it's got a balloon on the inside that we use to expand once we get in the right position. And so the valve itself has a metal frame, and then we blow that up with the balloon. You'll see the balloon come down here. On the inside of the frame are the leaflet tissue that now makes her new pulmonic valve.
And where does that, I call it the basketball net, where does that go? Does that come out the this right here?
The catheter here?
Yeah, or this little area right here, the little net.
No, that's the valve itself.
So that goes in and it's pulling it out.
The basketball net is the frame, the metal frame, and the leaflets are on the inside. Now the leaflets you can't see because they're so thin on this. You need the echo to be able to see that. And this is the arteriogram where we deliver contrasting. You can see before where there were all this leaking coming through there. Now it's going in the direction it's supposed to and not coming backwards.
And I asked you, I said, Dr. Tadros, he's our cardiologist.
Right.
He's in the procedure room with you. I said, is that normal that they come along with you? And you said, actually, it is. And tell us why.
That they come along.
That they come in there with you, doing the procedure with you alongside. Cardiologist.
So this is actually one of the cool things about our specialty is cardiology and cardiac surgery have really kind of merged over a number of disciplines, including heart failure, but in the structural realm, because this really marries, a lot of the skills that we both developed along our way to do this. So, this is the fastest growing segment of cardiovascular medicine is the structural heart. It is typically done. We do it almost every procedure here with both the cardiologist and a cardiac surgeon present.
It's so interesting because you think, your specialty doctor then, kind of hands you off to the surgeon.
Yep.
And they do their job. But it's kind of cool to see you guys working hand in hand, side by side.
It is one of the amazing things about the profession is, it was told to me early on that, what you do when you're done in your practice 20, 30 years from now is not what you trained to do previously. And so my dad was a cardiac surgeon, and when we get together talking about cases, it's very different because he's retired now, and the procedures that he did a lot of, we don't do a whole lot of now.
You both have to you must both look at each other in amazement.
Yeah, it's interesting. It makes for some interesting conversations. So.
Kaylee, this was, of course, not your first heart surgery or procedure, but it was the first time your fiancé went through this with you. Tell us what that was like. Was he nervous? What was that support like?
I would say he was pretty nervous. He was also just, I was the first person that he's known that's been that's had a major procedure like this. And he's never had anyone in his life have a big surgery or anything like that. So he was nervous, but we had Dr. Zorda and Dr. Tadros along the way. So he would ask them questions. He'd ask so many questions that I wouldn't even think of. And he felt very calm after talking with Dr. Zorda and Dr. Tadros. So throughout the process, he got more used to it and more calm. For my mom and I, we are very much familiar with this process. So we could tell that we had to help him throughout the process as well.
Well, that's what I was going to say. You're kind of a pro at this, if you will, because you've been doing this for decades, but you were there to help keep him calm along with your doctors. And it sounds like your recovery with this procedure wasn't so bad. Just kind of remind us again what that was like and how quickly you got to get back to your students and doing the things you love.
So I was back to work the following week. And then I had 2 days to prepare for students to come into the building. And then the Monday after that, I had students again. So it was a really quick recovery. The biggest thing that I think would be the hardest was I definitely had some fatigue. And I had to force myself to get up and continue to take care of my home or continue to take care of my body and say, I'm going to cook tonight, I'm going to walk tonight. So that was, I think, the biggest adjustment was getting to a point where I was no longer tired.
Dr. Zorda, we had a police chief on the other day, and we always talked about how once we get him back to doing well, we get him back to service in our community. When you get somebody like Kaylee back to her students, you're getting her back to the place she belongs, where she can be there for those kids that rely on her every day. That must feel really good to you, knowing that it's not just fixing Kaylee, but that ripple effect of getting them back to the life that they need to be at.
It is, and the little vignette where she talked about her husband coming in, it's hard to explain what it's like growing up your whole life having a heart issue. And you don't really have the normal childhood of just being carefree and not thinking about things. You're always conscious of that. And so when they get to this point where they get beyond that, and they get to a fix, and they get to go back and just so the interaction with her then future husband was interesting, because you see their worlds collide, and he's never, he didn't grow up thinking about those things, and he's got a wife to be that has had this as part of her life the whole time, and then watching her get over that. Now she's got that behind her for the moment. So
it's great. Dr. Zorda, Kaylee was, I guess, the first person in our region to get that certain heart valve. So what is new and special about that particular valve, and why does that make such a difference to have that one tool making that difference?
So it's an exciting time to be in this field, because there is so much energy and money being put into developing this. So this is the next an evolution of the technology, and the biggest part about that is it has the ability to accommodate a variety of anatomies. So one of the hardest parts about this is that the patients that have this condition have such a wide range of sizes, it's almost impossible to build enough valves that can accommodate, stay stable in that position, and do the function that they need to. So the benefit of this valve is that it provides that landing spot, or that platform there for the valve to work. The valve we put in, the actual valve part, is very, very similar to one that we've put in thousands so far in the aortic position, but it's the continued development of that with engineering changes. So.
Oh, well, we should let our viewing audience know that, Dr. Zorda, you're a man of many firsts, I have to say. So I hope red looks good on you, because this is where we kind of embarrass you a bit. But you're the first doctor in our region to perform all of these different procedures, like TAVR, core valve, valve-in-valve, tricuspid replacement, many more. But here's the weird question. Why you?
Yeah, so,
Tell us.
So it's mainly right place, right time. So I was fortunate that, when I came out, I had some of the basic training for a surgeon, which is the catheter wire skills, which was mainly acquired treating aneurysms or other kinds of disease process, and then wound up in positions where I had great collaboration, and most remarkably, it speaks to the program here. So I've had an incredible partner in Dr. Tadros with cardiology, who I've learned an incredible amount in catheter wire skills, and we've grown together in this program. And now it encompasses, a number of nurse practitioners and nurses, and the staff that's in both the cath lab and the ORs, and that have helped take care of these patients. So just kind of right place and right time. And once you get involved in one of them, the continual evolution of the products leads to the next one. So.
As a surgeon, how often do you get to see patients later down the road?
Or
just here when you come on our program?
So that's one of the benefits of this, and we, I've seen Kaylee before. We've talked about this. So this is one of the true benefits, because, typically as a surgeon or an interventionalist, you do the procedure, you see them follow up. You may have a follow-up visit afterwards, but a lot of these patients are doing so well, they don't really truly have follow-up visits with us, because they follow with their regular docs. And so getting to see this down the road is really nice.
It's kind of fun. Kaylee, what's it like to see one half of the dynamic duo this morning? We know you love him and Dr. Tadros, but what's it like?
It's always so great to see Dr. Zorda and Dr. Tadros. It just makes me really happy to hear from him, because although we only knew each other for he was part of my journey for a short amount of time. It's really great to see people who have such a big impact on my life.
Okay, speaking of your life, you have this big upcoming wedding celebration, but before we get to the wedding, you have to do the bachelorette party. It's this weekend, I understand. You gotta tell us the details. What are you doing?
So we are going to the big bachelorette spot, which is Silver Dollar City.
It's the Mecca.
I recently found out that the ride Fire in the Hole, which they've had for 50 years, is closing down, and that was a staple of my childhood. So I was like, originally we were going to do something around Kansas City, and I was like, I think we're going to change a little bit, and this entire bachelorette party has been built around Fire in the Hole closing.
Are you familiar, Dr. Zorn, with Fire in the Hole?
I'm not. I just heard about that, and so I've got to Google it and find out.
You must, because you're right. I think that is so cool you're doing that, because I think we never vacationed when I was little, but we went to Branson a couple of times, and The only reason I had a good time was the fire in the hole. That was so cool. So I'm glad you're giving a final send-off.
Yeah.
Good for you. That'll be really fun. We want to see pictures. Have a great time. Okay, so send in your questions for Kaylee or Dr. Zorn. You can use the chat on Facebook, YouTube. You could tweet us or email the Medical News Network. Info is right there on your screen. Let's get a quick check on our COVID count. Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control on this Friday. How are you?
Hi, doing good.
Good.
It's nice out. Right now, though, our active cases up a little bit. So 18 total, 9 active. Of those, 2 in the ICU, but 0 on the ventilator.
I have to ask you about this. The CDC published new data this week about COVID vaccine safety in kids that are very, very young. They're between 6 months and 5 years old. The data shows the mRNA shots were extremely safe, as we know. This was the first study to include kids who got a 3rd dose, but at the same time, vaccination rates for young children, as we know, are very, very low right now. But what are your thoughts on this?
Well, I think it is important to understand and publish this and have it transparent because we know, again, first, do no harm. We know that these vaccines, as many vaccines are for childhood and childhood preventable diseases, are extremely safe. This is more transparent data to support that fact. So do no harm, but also we know the vaccines, especially for those very young, can help as well. So that is the other concerning thing, is that the vaccine uptake in general has not been as optimal as we had hoped. And we also know that childhood vaccination rates are going down. But specifically for this vaccine, I think it's good, again, continued supportive evidence that what we are doing to try and keep people safe, particularly young ones, is safe, and that practice is safe, and the vaccines are safe as well.
Thanks, Doc Hawk, for
Yeah.
that. Do we have any reporters with us today? Let's get to some really good community questions. And the first one's from Lynn. Did the catheter procedure leave a scar, Kaylee?
It did not leave a scar. The only procedure that I've had that's left a scar is my open heart surgery.
Okay, so Perry wants to know, Dr. Zorn, would it make sense to repair Kaylee's valve or just replace it? And how do you know which is which? Or
Right.
which to do?
So unfortunately, we can't repair her valve.
Okay.
Her valve tissue is not sufficient to be durable and long-lasting because when we have to divide it as a young child, it damages it, and there's scar tissue in that area, and you can't repair. So leave her own tissue as a functioning valve. It has to be replaced.
So Paul wants to know, what is the valve made of?
So it has as you saw the balloon expanding, you can see it's got a metal stent frame, and on the inside of that, this particular valve has leaflets that are made by man from bovine pericardium. So it's the lining around the cow's heart. There's some that have porcine or pig pericardium. So it's not truly an animal valve. It is tissue from an animal that is constructed and manufactured to function as a valve.
Well, that's funny. Gene just popped up. Are the valve replacements human or artificial? Not human, bovine.
This one is bovine.
Okay.
We can use cadaveric human valves as well, and that actually was the mainstay for this when we did open surgery for a long time. And that's gradually been transitioning more to the prosthetic valves for a lot of reasons, mainly for durability and future interventions.
But why bovine?
So many things have been studied. The bovine tissue, so you have to find tissue that's both thin enough and pliable enough to function as a valve, so to move freely, but is also strong enough to hold against the pressure so that it doesn't leak, and durable enough to last as long as possible. And so the tissue goes through an intense treatment process to denature and get rid of all the immunogenic properties of it, but also to help stabilize it so that it can exist in humans for a long period of time.
Okay, T-7, and you've got to be up in the procedure room.
Right.
So a couple more questions. Teresa wants to know, will Kaylee need a new valve in the future, or is she as good as new?
She will.
She will.
So it's hard to say exactly how long these valves will last. Honestly, Kaylee represents, that is still in that initial wave of patients who are surviving these complex operations as kids, getting into adulthood. And so our knowledge of how long these valves will last is just not there yet. So we hope for somewhere between kind of 8 to 20 years of life before we have to start thinking about it again. the good news is that we are pretty confident we're going to be able to put at least another one back inside in the same fashion we just did by putting a valve inside her current one through the blood vessels in the leg. And we're quite optimistic that there's a lot of research and work going on, and that's going to help deliver something else, new technology for us.
And she'll be monitored up until that moment,
Yep.
so she won't get
Yep.
into any scary place where she doesn't see it coming. She knows
Correct.
it's coming, and you guys can monitor for that. Okay, a couple of questions, couple of good ones. Jean wants to know. I have to ask. I have no idea. Do you know what type of replacement valve Mick Jagger had a few years ago?
I'm pretty sure it was an aortic valve. I do not know what brand it was. So he had what's called TAVR, or transarterial valve replacement. And so that's on the other side of the heart. That's the aortic valve. So that is the valve that blood goes through, pumping from the left side of the heart, going to the rest of the body. Her valve was a pulmonic, which sits right beside the aortic valve, which is the valve that leads to the lungs.
So we got Mick Jagger, what, another 50, 60 years?
I'm not. We're going to have
Let's
to
be
check
honest.
that guy. I'm not sure. Yeah.
He's not.
He seems kind of cryopreserved already.
I think so. Okay, last question's from Jeremy. When you get together with Dad and talk, what's the largest contrast in what you do in your profession today versus what your dad did? You mentioned that earlier, but we kind of want to know the scoop on that.
So Dad had a similar practice in an academic institution, and so much of what Dad was doing at the time. So he was there at the early stages of lung transplant, and he helped develop lung transplant at his center, and that was one of his big focuses. But almost all of his procedures were open. Everything was either through the sternum or through the side of the chest, and we still do a lot of those. I still do a lot of those, but a lot of the procedures that he did that way, we are able to do now through less invasive.
So he thinks you've got it easy.
So he does. So for example, like a day like today when we're going to do 3 or 4 valves this afternoon, well, that's much easier to do catheter-based than it would be open. That's a pretty big day to do open surgery on that many patients.
Right.
And so and everything. So when the catheter-based patients go home the next day, then there's less people in the hospital.
Yeah.
So it helps in lots of ways. But when you have open surgery, there's more people recovering after that.
I'd like to be around that dinner table when you two battle it out on who had it harder.
Yeah, no, Mom doesn't let that happen.
I bet not. All right, let's get to our takeaways on this Friday. And Kaylee, let's start with you. What do you want folks to take away from your story?
I think the most important thing is to schedule your yearly checkups, but also just trust your body. If something's wrong, it will tell you, and you should see a doctor if something feels wrong.
Well said. Dr. Zorn, what's the takeaway?
Well, I'll touch on that too. Just, this is an incredibly exciting time for these patients who grew up with congenital heart disease and are now living with the benefits, but also the downside of successful surgery as a kid. And so it's so important to keep a close relationship with your doc. It's so important to, listen to your body, know your body, because, the options that we have now are so much better than we've ever had before, and they're going to get better even, going forward.
Interesting what you said, the downfall of a successful surgery, because then they
Exactly.
keep living longer and longer,
Yep.
and there's more work to do. That's so fantastic. Thank you both for being here with us today on this Friday. Thanks to all of our viewers and your questions as always. We leave you with some footage from a recent stress relief event for some of our health system staff. I love this. Puppy yoga. Coming up Monday on the Morning Medical Update. Too many men neglect their health until something goes wrong. I'm Jessica Lovell on the next Morning Medical Update. What stigmas and stereotypes are hurting the men in your life? An expert panel has the highlights and answers your questions. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.